without further ado, I give you Dr. Shaw.
Alright, I'm going to try without the microphone. Is that okay? You will find that I talk with my hands a lot, and I think this will go flying around. So if it gets to the point where you can't hear me, then please raise your hand and I'll grab the microphone. But I just want to start by saying thank you to Alan and Alex and Russ and the whole team of Animal Surgical. I'm actually the lucky one that gets to come to work every day and work with the most phenomenal group of people that I've ever met. It's the most cohesive, amazing, compassionate veterinary practice I've ever been into, and so I'm definitely the lucky one to be part of Animal Surgical today. Thank you all for coming out today. As Alan said, it's a beautiful day outside. The Seahawks are playing, and yet we're all here inside a room. But you can look out the windows, and we'll give you some breaks. And then Michelle's going to be our resident Seahawk updater as needed. And also, I just want to give a huge, let's all give a round of applause to our sponsors. Everybody's been to CE events, and you know that we can't put these things on without the gracious support of all of our sponsors. So make sure that you stop by and at least thank each and every one of them. Thank you, guys. All right, so we are going to talk about brachycephalic syndrome, and most people probably think of it as brachycephalic airway syndrome, right? Hopefully, this is going to be an overview. We've got about 20 minutes to talk on this subject, and then we'll move on to the regenerative medicine. So it really is going to be an overview. But one thing that I'm going to highlight, and I think you'll find, is that it's not just the airway, it's the gastrointestinal system. So we can call it BAGS. Acronyms work, right? I'll also introduce you to Beans. Beans is my French bulldog. She's 8 years old now. She was about 1.5 when that picture was taken. So BAGS, if you will, is near and dear to my heart, and I'm fortunate to see a lot of brachycephalics as patients, but I also get to live with one at home, and so I have some interesting perspective maybe. So we'll talk about their anatomy. It's really what makes them so cute. There was a quote in one of the textbook or article I was reading that mentions that the reason they're so cute is because they are perpetually looking like puppies or childlike, which that was an interesting way to describe them, but they are very cute. We'll talk about all of the different components, and I think this is maybe something that it was definitely news to me when I really started digging into this, that it is more than the probably 4 or 5 components of brachycephalic syndrome that at least I was taught in vet school and in residency. So we'll talk on that. The history and the examination, and really importantly, again, what owners think. Surgical intervention. So, we're not going to dive too deep into the how you do surgery, but I will talk about, some logistics of it, when's the best time to do surgery, and some nuances there. And then medical management. It's a very, it is a medically important disease process. And actually, there's one of the colleges in the UK has developed a whole brachycephalic department. So if you have a brachycephalic dog, or probably cat, you make an appointment with the brachycephalic department, and there's neurology, there's dermatology, there's surgery, and there's internal medicine, right? So we're just talking about the airway and the GI system today. We're not talking about all of the other stuff that goes along with these guys. And then the prognosis. And sadly, there was a study that came out a few years ago that looked at the most common cause of death for all the different breeds, and respiratory distress or respiratory-related symptoms was the #1 for bulldogs. That's the sad truth. But hopefully we'll talk about some things that maybe can help with that. So this is actually my first Frenchie, Millie. She was born with Atresia A9. That is not a good condition. She's no longer with me. That one didn't turn out as well as Beans, and we're not going to talk much more about her. But French bulldogs are very popular. Any other Frenchie owners in the room? I know there's at least one. Anybody else have a Frenchie at home? How many people saw a Frenchie this week at work? Right? So in the U.S., there's this dramatic increase in French bulldogs. I don't know, was it Modern Family that they were, became on TV, and so everybody wanted a Frenchie? So a pretty dramatic rise in 10 years from 38 to #9 in the AKC ranking, and in the UK, an even more dramatic increase. And so they're cute, but this is, you can find articles that talk about this is actually a serious welfare issue. These guys cannot breed on their own, right? Over 80% of them need to have give birth. And then they can't breed very well on their own either. And the more selective breeding to make them cuter, and they've got wonderful personalities, it also does contribute to their whole brachycephalic syndrome. So it is getting worse. And most owners don't even recognize that this is a problem. They snore and it's cute, right? It's kind of like the Yorkie that hops and skips with their MPLs and it's just cute. One of the things they do. So there was actually a survey that came out, this was done in the UK, it was actually published by a German group, and they surveyed 100 owners of French Bulldogs and Pugs. And I'm not going to go through every single question, but the mean age was around 3 years at the time they were taking the survey, at the time that they noticed problems in their dogs. It was around 1 year of age. And almost all of them did recognize that as the dogs got older, the condition got worse. Okay? So what did they find? Loud breathing when exercising. That's a no-brainer, right? A lot of them, or most of them, had difficulty sleeping. Over 90% had trouble sleeping, and that ranged from just snoring loudly to actually sleep apnea. Sleep apnea was, in another study, more common in English bulldogs, but it was recognized here. And then even at rest, making weird sounds. Choking fits. Now, I'm not exactly sure what choking fits. This was, the layman terms for the clients filling out these questionnaires, but a choking fit in 70% of dogs seems pretty significant. And at least once a week, about half of the dogs are having choking fits. Collapse, a third of them have a collapse in their life. And then cyanotic, and then 7% of them once a week are getting cyanotic. That's not insignificant for me. And then reverse sneezing. So reverse sneezing, very common, actually more common in brachycephalic dogs. The whole mechanism of reverse sneezing is a reflex within the nasal cavity, and it's designed to clear irritants from the nasal passages. And with chronic irritation and inflammation in the nasopharynx, they're more likely to have that reflex kick in and have reverse sneezing. The number one complaint, though, is exercise intolerance. How many of you guys saw more complaints of this summer with the heat? Anybody else? I definitely, saw a lot come in for surgery, and that was their number one complaint, is they had exercise intolerance. So part of the study is they surveyed not only brachycephalics, and they had their control group, which was the quote-unquote normal dogs, or mesocephalic normal noses. And these graphs, so the gray bars represent summertime, the black bars represent wintertime. And so this question is, how long can you go for a walk with your dog? And so this is the brachycephalics. Most of them could not walk during the summertime any longer than 10 minutes. And so what I want you to see is the difference between, so this is summertime versus wintertime. And as the temperature dropped, they could start going for much longer walks out here. Versus these guys over here, really, it didn't seem to be an issue. They could go for walks, and that was unrelated to their respiratory signs. So the next question was, well, how long does it take for your dog to recover after you've gone for a walk? And again, so this is going to be summertime, this is wintertime. So wintertime, pretty short amount, so 5 to 15 minutes. Versus summertime, up to 60 minutes, over 60 minutes. So 30 to 60 minutes, the majority of our dogs are taking, up to an hour or more to recover from exercise. Versus the mesocephalic dogs are really a standard time. This is the magic number of temperature. This makes us grateful to live in Seattle because most of the year our brachycephalics can go outside. But it did seem that the temperature, and there was a range, but the average temperature where the respiratory distress and the exercise intolerance and difficulty recovering was around 66 degrees. So the other thing that came out of this is that most of these dogs, or at least half of them, had recognized signs of GI issues. So half of the dogs had problems eating at least once a day. And this was more common in French Bulldogs, and that is beans. Her butt. And so at least once a day, so Pugs, French Bulldogs, so choking on food, a quarter of the dogs, once a day choking on their food. Vomiting and regurgitation, almost half of them every day are vomiting or regurgitating. And then dyspnea during feeding. So that's pretty significant. And then otherwise they're out here, once a week, once a month, and then rarely. And so again, this did seem to be more common in French Bulldogs versus Pugs. All right, so the components of brachycephalic syndrome. So the different pig colors didn't show up quite as well, but the underlined, these guys are the ones that, the traditional brachycephalic airway syndrome, okay? So, stenotic narrowing, elongated soft palate, verted saccules, laryngeal collapse, and hypoplastic trachea. Those are the main ones we were taught, right? Actually, this is all going on. It's all components to it. Not all of it can we fix. Okay, so not all of it can we fix with surgery. Not all of it can we address even with medical management. So hypoplastic trachea, there's nothing that we're going to be able to do about that. On the flip side, however, studies have shown that the hypoplastic trachea alone doesn't seem to contribute to a negative outcome in those dogs. I don't know if you can sort of appreciate that there's a difference in color. The averted tonsils and these glottic ones and bronchial collapse, those are actually secondary to the underlying primary conditions such as stenotic nares and obstruction in the airway. So there's a primary component, and then over time, that resistance in the upper airway does contribute to lower airway conditions. I'm not going to come back to it any more than this, but bronchial collapse, there's an interesting study that it was more common in pugs, and it tended to be progressive, that the bronchial collapse was related to how severe the upper airway syndrome was. And it was the left cranial bronchus that was more likely to collapse, which interestingly enough is the same lung lobe that is more likely to torse in pugs. So there was a hypothesis that perhaps lung lobe torsion in pugs was related to their bronchial collapse and underlying brachycephalic syndrome. All right, so the consequences of no nose. So what have we done by breeding dogs and taking away their nose? Well, we've made them awfully cute, right? But if we look at a CT scan and chop straight through the middle of their head, and I use the CT scan when I talk to clients too and explain what's going on here, what we can address and what we can't address. Is if we look in the CT, so this is the hard palate, the white just for reference, hard palate here, hard palate here. So what I want to look at is these are all the nasal turbinates in the choana, and all of them have been shrunk into this area. So we've taken it and shrunk it all down, okay? Also, this is a soft palate, like how thick that is, and kind of running off the page, but it's overlapping. You can even see on the CT, overlapping epiglottis versus a normal size soft palate. Relative, like this is a pug and that's a German Shepherd, so that is much, much thicker. So it is a domino effect. So we have an increased resistance in the upper airway, and it becomes this domino effect that progresses down into the larynx and then eventually down into the bronchi. And it starts here with stenotic nares. Not all dogs, not all brachycephalics have stenotic nares, but if they have stenotic nares, we need to address them as soon as we can, because it does contribute to that increased resistance. This is an end stage. That's laryngeal collapse. And so just for orientation, those are your laryngeal saccules, which the version of the laryngeal saccules is stage 1 of laryngeal collapse. But once you get these processes, the retinoid processes collapse down, that's the end stage, and that's bad news. There's not a lot of good stuff we can do at that point. So this was an interesting study where they looked at the choana. So again, one of the components that we're not as familiar with, these are the terminus and the choana inside the nose. This is a normal, quote unquote normal dog, mesocephalic dog, and you can see airway comes through. There's plenty of room for the airway to get through. These are the mucosal contact points, and so that's resistance, that's blocking the airflow through the nose. And this chart just shows, so again, this is 0 is the kind of blue, that's 0 contact points, so that's 0 places where resistance to air is being met. So a quote-unquote normal dog, normal nose dog, really not many contact points, versus the French Bulldogs were the worst, worse than pugs, they had more contact points. So part 2 of this study was actually, this was done in, over in Europe, and they used a laser, a certain type of surgical laser to ablate the choana. And so they took out, they basically kind of rotor-rooted the choana, and then went back and followed it up. And there was regrowth in many of the dogs, but it did seem to help. I don't know anyone around that is doing it locally, but I think it's something to watch out for, that we may be doing that in the future to just open up the nostrils. Another part of this is looking at other things going on in the nose, and pugs, they are very likely to have septal deviation, so nasal septal deviation. This is a CT. This is the septum. You can see it's deviated that way. You can see that deviated over to, I'm not sure if that's right or left, but about half, almost all of the pugs had septal deviation one way or the other. So that means that one nostril is not going to be working so well. There's not going to be much airflow through there. So what can we do? So this is probably the most important thing. The airflow past those choana are important negative feedback for the growth. So the choana actually continue growing as the puppies are developing. And if there's airflow past them, it says, okay, stop growing. Airflow needs to come past. So if we have stenotic areas and we don't have airflow going past the choana, that's going to be, we're going to miss out on that negative feedback, and they're just going to keep growing, and you're going to get those contact points. So that's the argument for getting those nostrils open as soon as you can in the puppy's life. So the recommendation is somewhere around 4 months of age. So nasal mucosa is important for olfaction, but it's also very, very important for thermoregulation. And this is why these guys have a really hard time thermoregulating and recovering from exercise. Is that the mucosa in there, there's less of it, first of all. There's less surface area for the air to come through and have that cooling, that thermo-regulating mechanism is deficient. It's not working, and it's barely present for these guys. And then aberrant concave present in 100% of dogs. So that actually, so there's sometimes they will poke back into the pharynx, so there'll be nasopharyngeal concave and turbinates, and then aberrant ones in places where they shouldn't be. So I'm bringing this up because we can address our stenotic areas, elongated soft palate, and the other things we'll talk about, but at this point in time, we're not addressing everything that's going on in the nose. So it means we should still do surgery, we should still do everything, but we can't expect 100% improvement. We're not going to take a French Bulldog and make them into a German Shepherd. All right, so what are the respiratory signs that we see? This is Beans. Not too long ago. Everybody hear that? Can I see it? Anybody have clients that have reported similar coughing or you know, whether it's regurgitating or coughing, or does it kind of look like kennel cough? I hope it's not. But so this is part of the syndrome, and she does have some significant GI issues that I'll talk a little bit more about as well. But this is for her, it's an almost daily occurrence, if not multiple times a day, and I'm working through it. But it has gotten worse, and she's had all of the surgery that she can have. I'll talk a little bit more about what we're doing with her. But the snoring, stridor, that's the most common one. That cough, which was demonstrated by Beans. Reverse sneezing. So stridor versus stridor. Stridor is more snoring. Stridor is more of a musical, laryngeal, higher pitched sound. All of these guys, sleep apnea. And again, it is progressive. All right, so talking about the GI stuff. So this is another study, again, out of the UK, and they looked at the prevalence of GI, so esophagus, stomach, and duodenal irritation or abnormalities in dogs that were presenting for upper airway signs. So these dogs were coming in to have their upper airway addressed, and they did endoscopy at the same time. And so basically, almost all of them, 97% of them, had some sort of GI component going on. And not all of the owners reported that that their dog was doing any coughing, any regurgitating, any difficulty eating. So we can pretty well assume that all of our brachycephalic dogs do have some sort of GI component going on. These are the different components to it. And I think that you guys have these notes somewhere, but it was a mixture of inflammatory, so esophagitis, duodenitis, gastritis, and more mechanical things, hiatal hernia, pyloric stenosis, pyloric outflow obstruction. So all of these things were present in these guys. And so we do have another part of the domino effect. And hiatal hernia, it can be a congenital problem that they're born with. It can also be progressive due to that increased upper airway resistance, that trouble breathing over time is going to suck the lower esophageal sphincter into the thoracic cavity, and we lose the function of our lower esophageal sphincter. So this does become a progressive domino effect, and we get severe esophagitis. So my dog Beans, the only thing that she's been hospitalized for on an emergency basis has been severe esophagitis. where she is so painful that she can't, she can't swallow, she doesn't want to move, because she gets severe esophagitis. So the clinical signs that we see, we'll have to demonstrate again. Something actually came out that time, so we'll call that a regurgitation. Dilated stomach, flatulence, all the wonderful things that we get French Bulldogs for. So they not only looked at the diagnosis, but then they went ahead and treated them medically. So these dogs all had surgery for whatever component of Briggs Cloud syndrome they had, and then they were treated medically, and I'll show you what the medical component was in the next slide. But over 80% of them did resolve, or not resolve, significantly improve in both the respiratory component and the GI component. So the severity of the respiratory component was directly correlated to the severity of the GI component and vice versa. So managing both parts of that is I guess, the take-home message. And from the medical standpoint, omeprazole is a proton pump inhibitor. It's a phenomenal drug. However, if you are going to put a dog on it forever, you have to recognize that if you take away omeprazole, it has a negative feedback that you take omeprazole away, you're going to have this super spike increase in acid production that's going to have a rebound heartburn effect. In people, it's actually a model of creating gastric tumors in rats. So if you commit a dog or yourself to it for more than the 2 weeks that it's labeled for, just understand that it's not as easy as just stopping. However, if it's needed, it's a really, really powerful, wonderful drug. So I would say that I've just recently started beans on it, and it's my good plug for Shiraz over there. So we're getting the omeprazole compounded for 0.7 mg per kg once a day. Or you can do Pepcid. So most of the time when I'm doing surgery, these dogs get an injection of omeprazole or pantoprazole before surgery, and then they're going to be kept on famotidine unless they do have severe GI component to it. Cisapride, so in that previous study that I mentioned, it was omeprazole, famotidine, and cisapride. And cisapride is a prokinetic that's been taken off the market, and it's pretty hard to find these days. So if you can find it, you can try it out. There are some pretty serious side effects in humans, that's why it went away. You can also try the Reglan, metoclopramide. Sucralfate, so sucralfate is absolutely indicated if there is any sort of ongoing esophagitis or gastritis. Prednisone, so for surgical patients, we do give steroids to decrease pharyngeal edema, and then if it's severe, we'll keep them on Supred for a period of time. And then Cerenia can also be a good one. We do give it preoperative. So this is going to kind of blow through these. This is a little bit older study. This is looking like the before French Bulldog days. So this is actually out of Mississippi State, where their mascot is a bulldog. So English Bulldogs represented most of this. This is the first one that really talks about everted tonsils. So the tonsils, the pharyngeal tonsils, can become everted, and they can start obstructing the airway just by having more mass, more tissue obstructing things. So about half of the dogs in this study had everted tonsils, and most dogs had 3 or 4 components that they described going on. Dogs with stenotic nares more likely to have elongated soft palate. This is the whole domino effect going on. And they saw 12% complications, which wasn't necessarily 12% mortality, but it was aspiration pneumonia, complications related to surgery in general. Around the same time, this one came actually out of a private practice in Ohio, fairly similar population, pre-Frenchie. English Bulldogs most likely to have hypoplastic trachea. Don't do anything about it, but it's something to talk to owners and say, your dog, especially with the Bulldog, probably has a narrow trachea. We're not going to be able to correct that part. It's also important when you're intubating to understand that they probably need a smaller ET tube than you would think. None of the dogs had everted saccules alone. Now I will talk about, so my dog Beans was born with a cleft palate. So she had a very short palate. So she's never had an elongated soft palate. I did her nose when she was about 6 months of age, and she did great up until this summer. And this summer it was bad. And so my dear colleague Dr. Bennett took her saccules out a couple weeks ago. And so she is an example of that sometimes dogs, even if they've had surgery in years earlier, they can then develop more progressive components to it. And it's probably because she's got stuff going on in her nose that we can't address. 94% had 3% mortality. Across the board, the mortality rate is not high. It's around 3%. So I think we get scared of the waking up from anesthesia, and it's a legitimate concern, and we take it very, very seriously. But the perioperative mortality is and it should be around 3 to 5%. So the favorable long-term outcome, regardless of age, breed, or number of combination of conditions. So just a quick run through of what we do surgically. So this is Coop. He is getting pre-oxygenated. He's got his catheter in. He's got fluids running. The fluids have actually Reglan going at a mg per kg per day, IV, and we keep him on that after surgery. He's gotten his omeprazole IV. We have a series of endotracheal tubes, and again, he's going to get pre-oxygenated for about 3 to 5 minutes before we induce him. Once he's induced, I do an oral exam, kind of understand what are we dealing with, look at the soft palate, look at the tonsils, look at the larynx, inverted saccules, and then intubate them. And then once they're intubated, then we get all the monitoring equipment hooked up, we get all of our surgical stuff ready. And then most of the time we are using the laser for most of the intraoral component. And this is, I don't know if you can see, that's a tonsil. So he did have everted tonsils. And then this is a picture of the soft palate. And the soft palate should be trimmed to the level of the caudal aspect of the tonsillar crypt. And there's some new techniques that talk about doing like a palatoplasty, where you fold over part of the palate. I think most of us are using the laser. It's quick and easy, no bleeding, good recovery. I mentioned we do give steroids preoperatively unless the dog's been on non-steroidal otherwise. And then for me, this is the order that I do things. So my colleagues may do it differently. And then do the nose if indicated. And part of my reasoning for doing it this pattern is the first thing I'll do is the saccules, and then have that endotracheal tube kind of compressing if there's any bleeding there, and kind of work from in to out. Some people do it the opposite direction. So recovery, they need an e-collar if they've had their nose done, so that they don't scratch out or rub their nose on the floor. And no chewing on hard objects. So this is me a couple Halloweens ago with their pumpkin. So soft food only for about 2 weeks if you've done anything intraorally. So end stage. So the progression of this, the domino effect, what we're trying to avoid, can end up in some devastating consequences. Heat stroke. So a large proportion of dogs that present for heat stroke are brachycephalic. So really trying to look out for those guys when it's hot out. If they have laryngeal collapse, the two reported treatments, one is laryngeal tieback, so arytenoid lateralization, similar to what we would do for dogs with laryngeal paralysis. However, the described surgical technique is a little bit different than what we do for a traditional tieback. And there's some controversy there, because some people feel like if you just do a tieback, it's going to pull the whole larynx over to one side, and you're still going to have some collapse. There was a recent study that showed in a group of dogs it was successful doing a tieback. There may be some breed discrepancies there too in terms of which dogs have more rigid cartilage versus flaccid cartilage. Or you're left with a permanent tracheostomy, which is, it's a big commitment for everybody involved, and not one that most people undertake. I've only ever done 2. Aspiration pneumonia, that's always a potential consequence too. So, in terms of for you guys seeing bulldogs all day, or not all day, but on a regular basis, and things to consult with your clients about is really the commitment that they're getting into. I mean, bulldogs, especially Frenchies, have wonderful personalities. They're adorable, but they're a big commitment. So you can find this stuff all over the internet. My bulldog's breathing loudly. Is that weird? Is that strange? Not for a bulldog, but understanding what they're getting into. And the most expensive breed to own, this says American Bulldog, which I think is not correct. I think it has to be English Bulldog. But they are the most expensive breed to own in terms of veterinary bills. So actually, we should all want them to be bred, right? So just, one little thing you can suggest to owners is to watch their tongue. So when a dog, any dog, but especially a Briggs phthalates, when their tongue gets to that point where it's curled up at the end, that's their end of their reserve. They have no more eating like reserves left. And you don't want to get to that point. So watching them play, you want to stop play and be the fun police early. They've got to stop playing earlier and not get to this part, because that's when they really run out of reserves, where they're going to take 30, 60 minutes to recover. So just kind of in summary, take home. So correct stenotic areas as early as you can. How many of you guys are doing those with time spay or neuter? Good, so a good handful. May need additional surgery earlier in life, later in life. So even I recently did an English bulldog who had kind of the whole bulldog special done at WSU when he was a young dog. He was 10, so a 10-year-old English bulldog, otherwise doing pretty well, but his soft palate was very, very long, very, very thick. His saccules were everted. And that was actually his nose that was on an earlier picture. So we did have to redo it several years later. Weight management, very, very important. That's part of the whole management of them. If possible, don't take them to the dog park to walk them excessively when it's hot out. So early morning walks are going to be the most ideal for them during the summer. Really try and counsel owners not to take their dogs running or to the dog park, especially during the summer. Use a harness. Light sedation, anti-inflammatories as needed, and so especially if I've had some clients who will have some ACE or Torb at home, if they know that there's going to be a big event that their dog might get overworked, they can give that to them ahead of time. And then treat the GI component. So we think of the airway component as Briggs phthalic syndrome. It's BAG, Briggs phthalic airway and gastrointestinal syndrome. All right, so that was a quick run through, but any questions? Yes, Randy.
Have you had any with the food treating the GI tract, like EN or HA or IBS?
So the question is, any luck changing the food, treating the GI tract? I haven't, but I have to admit that this is all kind of new to me, is trying to really tackle the medical side of it. It wouldn't be a bad idea, I don't think at all. Yes, Sarah?
Do you have a specific time, morning or night, for the omeprazole? Because when I used to be on it, I didn't take it at night.
Yeah, so the question is morning or night for the omeprazole. I give it in the morning. You're supposed to give it sort of on an empty stomach with a glass of water, or with some water. For me, logistically, I give it first thing in the morning to my own dog. I don't know, honestly, I don't know if there's a benefit one way or the other. It's not, so if you have an acute esophagitis, gastritis, I would also combine Pepcid or Commodity. The omeprazole takes a few days to kick in, so I would combine those for a period of time. But I honestly don't know. Was there another question?
Yeah, when you're correcting the stenotic areas, I've seen all kinds of different attempts.
Yeah.
How deep do you go? Can you go as deep as you can get?
Yeah, so the question is, the surgical technique for correcting stenotic nares, how deep can you go? Pretty deep. I mean, yeah, so I do the wedge portion, and so leave a part of the medial aspect, and it's pretty deep, like a pie-shaped wedge out, and then suturing them out. I go pretty deep and pretty aggressive to get them open. Yeah.
Did you say when you have the everted tonsils, do you just resect those, or are you doing something else?
We're resecting them. We're using laser to resect them. They bleed, so you could, just like the soft palate, you could resect them sharply, but you want to be prepared for bleeding. The concern is that any bleeding or any increased inflammation in the throat after surgery could lead to worsening signs. So I've honestly never done them with anything other than a laser. Is there another question? Yeah. So the question is, do we ever put in a temporary tracheostomy tube for my more severe cases? I haven't had to. In the most severe cases, I'll prep them, I'll shave the neck, and talk to the owners about it, and have everything ready, but so far I have not had to. Any other questions before we move on? Alright, what is the score update?
We're currently in overtime, tied at 24.
Yeah.
Seahawks do have the ball though, so they know.
Alright, so we are going to move straight into the stem cell talk, regenerative medicine, and then we'll take a little bit of a break after that.
Yeah, that's fine. In between here,
I just want to put in another plug for all our sponsors that are helping us out with this. For us to put on an event of this size is pretty daunting, and certainly having them on board and helping us out is fantastic and make it all possible for us to put on a little bit bigger event like this. So please, in between breaks and such, to talk with them, thank them for helping us out. And I think they've got all kinds of good information and maybe some freebies for you and such. So don't forget to stop by and talk to them.
All right, shifting gears completely. So, as Dr. Johnson mentioned earlier, my two passions, they are kind of polar. Soft tissue surgery and rehab and sports medicine. They don't obviously go together, but that's what I love. So I do get the opportunity to do both and practice both. And how many people doing stem cell therapy or PRP, regenerative medicine here? A few people. Great. Anybody had any cases that have been treated other places? Curious about it? Okay. So again, this is going to be a quick overview. What time do I finish? Okay. So it is going to be an overview of regenerative medicine touching on stem cell therapy, platelet rich plasma. So anybody hear about the patient in the UK who recently had a stem cell therapy for macular degeneration trying to cure blindness? Yeah, so my mom has macular degeneration, so we're following this really closely. You know, it's a big hope to think that that would be available for, you know, to treat, you know, our relatives or ourselves if needed, but it really is the forefront in the future of medicine, I believe. And so, you know, a few years ago, not that long ago, it was kind of hokey, right? You say stem cell therapy, and even now, if you Google stem cell therapy, you're going to get a lot of facial rejuvenation and live forever and grow a new ear. So there, you have to sift through the real science that is there and the kind of marketing side of facial, you know, beauty stuff that goes along with it. So regenerative medicine is the use of multipotent or pluripotent isolated cells that replace or induce the regeneration of damaged tissue. Okay, so it's either replace, but more importantly, they're inducing. So we're putting these cells, these factors, these growth factors into an area and having them try and stimulate the local environment to heal. And so compared to our traditional pharmaceuticals that have one specific receptor that they block or they stimulate, these guys have a multitude of effects. So you give especially stem cells, they're going to have effect on a variety of different cells, and then consequences from affecting those cells. We can have autogenous or allogeneic, and this is going to be very important in the next few years as we have both products becoming available. So autogenous means that we are collecting stem cells from that individual and giving them back to the same individual. So in dogs and cats and horses right now, almost all, well, I would say all of the commercially available stem cell therapy is autogenous. So we're taking the dogs, either their own fat or their own bone marrow, isolating the stem cells and giving them back. Allogeneic means that we're taking one dog's stem cells and giving them to another dog. All right? Does that sound crazy? Like we're going to have crazy graft rejection? It's actually not. So one of the properties of stem cells is that they are immunoprivileged. So they lack the receptors on their surface that will stimulate an immune reaction. So the future, I think, of a lot of our, especially treatment in canines, is going to be allogeneic or off-the-shelf stem cell therapy. And it's probably a couple of years away, but it's something to look out for. So when we talk about stem cells, there are, you know, there's embryonic stem cells, which is, I believe the macular degeneration study was using embryonic or pluripotent stem cells. We're talking about multipotent or adult stem cells. So these stem cells have a defined lineage. They can't differentiate into everything anymore. They have a defined lineage, but most of these can differentiate into bone, cartilage, muscle, other soft tissue. And so that's limited. We're not going to create a whole new joint. We're not going to create a whole new being. We're not going to get a teratoma with them. So these are the main properties of regenerative cells or stem cells. So they can differentiate into the different tissue lines. They can induce repair. So this is probably one of the most important things is, again, telling those other cells in the local area to heal, to repair. homing. So they actually can be, there are a number of studies, mostly in lab animals, where stem cells are injected, say, IV or into the peritoneum, and they will home into an area of inflammation or damaged tissue. So they do respond to areas of that need to be healed, which sounds kind of crazy, but it does make sense. If they have a receptor, there's an area of inflammation, they're going to home to it. Immunomodulation, so this is a big one. So immunomodulation means that they are modulating the immune response. So they're affecting our B cells and T cells, macrophages, in the area to have a different response. Anti-apoptosis, so they're preventing cell death, and then cell renewal. So this is just a example of an immunomodulatory effect. So our CD4 cells, T regulatory cells, these guys, especially these, are very important in cancer. And so there's a whole branch of stem cell therapy that's looking at the role of stem cells in cancer, from the cancer treatment and from the what happens if we give stem cells for, so they're looking at breast reconstruction, giving stem cells, but what does that do for the potential to, induce neoplasia or have a regrowth of it? So there's a lot of unanswered questions at this point. All right, stromal vascular fraction. So when we do adipose-derived stem cell therapy, which is what the VetStem product is, we collect adipose, we send it into VetStem, and they isolate the stromal vascular fraction. And within the stromal vascular fraction is our mesenchymal stem cells. They're a component of it. So actually, when we do adipose-derived stem cells, it's not a pure homogeneous stem cell therapy. It's actually stromal vascular fraction, which sounds like, oh my gosh, I've been cheated this whole time. I thought I was giving stem cells. There's actually something to it. There's other cells within that stromal vascular fraction that have been shown on their own to have beneficial properties. So endothelial progenitor cells, so they may be the guys that help in angiogenesis. M2 macrophages, they're important in immunomodulation. And again, T regulatory cells. So it's this kind of soup of stromal vascular fraction that includes mesenchymal stem cells. Versus, if we do bone marrow, for bone marrow, you can't get enough stem cells out most of the time, at least in a dog, so you have to culture them out. So you're going to get a cultured plate of homogeneous stem cells. When we do allogeneic stem cells in the future, and there's some studies going on currently, those are going to be pure stem cells, not stromal vascular fraction. So you can make an argument which one's better. I don't think that anybody really knows, but it's just so you're aware. So autogenous stem cell therapy, as we have available to us now commercially, we typically collect the fat. I like it from the falciform. It's the most predictable place. I've tried to collect from behind the scapula or inguinal. Those places are much more likely to develop a seroma or have wound complications versus do a small approach to the abdomen and take out the falciform. High source of mesenchymal stem cells, and usually you don't have to culture them right away. Minor surgical procedure, and there is a good bit of evidence and research that supports its use. We can also do bone marrow. Again, the bone marrow does take weeks to culture out those cells. There are arguments on either side with bone marrow versus fat, and I don't think anybody has the real answer yet. So just an example of if I'm doing stem cell therapy, it's I'd say half the time. Many times combined with doing elbow arthroscopy is probably the most common one. Otherwise, we're just doing stem cell therapy. We do it's a surgical procedure, collecting the fat, put it in a sterile container, ship it off to VetStem. Gets there overnight, and the next day they have a beautiful lab. It's an amazing quality controlled lab that I've visited a couple of times. They do the processing and they stick it back in the mail that day, so that the following day I get the stem cells back and ready to inject. And they do bank any extra doses. So if you collect fat and you say, I want 2 doses to give into both elbows this week, any extra doses or extra stem cells will be banked for future use. So that's one of the benefits is if we have a young dog and say we're doing elbow arthroscopy, we can collect the stem cells at that time and treat them 2 days later and then say, okay, well, we can come back and treat your dog every 6 to 12 months with their stem cells as needed, and we don't need to do another surgery to collect that fat ever again. So those banked doses will be there for life. When you run out of banked doses, then they have what's called a retention dose, which is they always hold this retention dose, which can be then cultured to make more stem cells in the future. So once you collect the fat for that one dog, I've never had to redo surgery. You have stem cells for that dog for life. Do you have a question?
Oh, I just was wondering, when you refer to elbow arthroscopy, is it diagnostic or just, is it therapeutic?
Both. So I mean, we talk about elbow arthroscopy as diagnostic or therapeutic. We go in there with the hope that it's therapeutic, but sometimes it is just diagnostic, especially one side's more clinically relevant than the other. We'll scope both sides and say, this side that has a mild cartilage erosion, but we're not going to do anything clinically. So then day 2, they come back. So let's say we're doing an elbow scope. We would anesthetize on a Monday, do the scope, collect the stem cells. They would go out to that stem Monday night. Tuesday, the dog goes home Monday night. The dog's at home on Tuesday, comes back in on Wednesday morning for a brief sedation, injecting the stem cells into the elbow, both elbows. That's just an example. This is the general cost to the owner for the stem cell part. That's not including any other surgery, but that's for our collecting the fat, and then the processing part. The nice thing is a lot of insurances will cover this. I've had two companion cases recently that dogs had elbow scope and stem cells. So indications for stem cell therapy, OA is probably the biggest one. Ligament, tendon, muscle injuries, osteochondrosis, osteochondritis, that's going to lead to OA. Immune-mediated polyarthritis, so one of my very, very first cases, probably 2007 or 8, was a little Labradoodle with awful immune-mediated polyarthritis. And, we had started fusing joints, and then it just became like a domino effect. And we treated with stem cell therapy, and the dog was not functionally awesome at all, but in terms of pain management, it did seem to have a pretty profound effect. And so I think there is some promise there for immune-mediated polyarthritis. Really interestingly, in the research side, there's Crohn's disease in humans, which is analogous to perianal fistulas in dogs and IBD. There's some really interesting research there. There's a dog model of Crohn's disease using dogs with perianal fistulas treated with stem cells, and some pretty dramatic results there. Other things that are not up here because they're not really advertised, but there's some research going on for dilated cardiomyopathy in Doberman, some IBDD stuff, so some direct injection into the spinal cord, and a research component for chronic liver and kidney disease. So interestingly, there's a study in dogs where they injected stem cells either into the portal vein, into the spleen, or IV, and tracked with scintigraphy where those stem cells went. And a couple things that were interesting to me on that. When you give them IV, they go to the lungs first. So the stem cells go and set up in the lungs. So we don't know what the consequences are of that. So I used to give an IV dose along with my intra-articular doses, and I've moved away from that because I don't know the consequences of the stem cells going through the lungs first. But you could inject the spleen with stem cells, and they would go to the liver, and there was some promise there. So I would love the opportunity at some point to try stem cell therapy on a dog with chronic, end-stage liver failure where there's no other options for it. I was almost involved in a chronic kidney study when I was still at the University of Florida, but there are some of the universities doing research for those conditions as well. So outcomes and expectations. This is data that was shared with me from VetStem, and I would say I've probably treated 25 to 30 dogs in the last, 8 years or so, 7 or 8 years. And I would agree that 75% of the dogs have a positive outcome that the owner will see within the first 2 months. And they continue to see that improvement, about 80% of them after 90 days. Of course, the argument is they've dropped $3,500 on this, right? So is that a giant placebo effect? I don't know. I honestly don't know. We'll take a look at some of the research that does support its true value. I would say almost every case that I have treated, the owners are saying that it's working. But you have to set expectations. So this immune-mediated polyarthritis dog, I was not going to cure that dog and make normal joints again. It was more of a pain management, let's do something. And I'd say that's usually the case. I'm almost always using stem cells for elbows where, to be honest, we don't have any great surgical treatments. We can do arthroscopy, we can take out fragments, we can treat the cartilage, but long term we don't have awesome things to do for the elbow. So that's usually where I'm using it. So just a couple studies we'll touch on. These came out several years ago. So this was a double-blind, placebo-controlled, randomized trial of dogs with hip arthritis. And they were randomized to either have stem cell, this was an adipose-derived autogenous stem cells, or placebo injected into their arthritic hip. And so these graphs are looking at, this is the time of injection, 30 days, 60 days, 90 days. So this is the placebo group down here, this is the treatment group. This is range of motion, significant difference obviously there. And we're starting to see as early as 30 days. Improved lameness and pain on manipulation. So this is the lameness at a trot, pain on manipulation. So the lameness, one thing to notice, so you definitely see, if you're going to see a response, I tell clients, you're going to see it in that first month, based on the evidence. And you may continue to see improvement out to 90 days. They didn't track it any further, so we don't know if it sustains for that 90 days or it drops down. I'd say anecdotally, most of the dogs I retreat are every 9 to 12 months or so, sometimes even longer. This was another one, dogs with elbow OA. So this time it was not placebo-controlled, was not blinded. So in terms of our evidence-based medicine, a little bit lower on the pyramid. But these dogs at 0 days followed out here to 180 days. There was significant improvement in all of the parameters that they looked at. Again, this was not placebo-controlled, it was not blinded, but they did see an improvement with these dogs. This is just a case report, so lower down on the evidence-based medicine scheme, but 2 dogs with acute semitendinosus tears. These were working dogs. They were treated with intralesional injection of stem cells in the week or 2 after the injury, and followed out with ultrasound, and they did make a complete improvement. So just an example of using it for a non-OA type case. And then this is a more recent one. This is actually out of Spain, and these are dogs, again, with hip OA, and their outcome measure was a force plate. So they walk the dogs across the force plate where they measure how much of their body weight. It's like a scale built into the floor. And low number of dogs. So 8 dogs versus 5, so it's still a pretty low number, but they did see significant improvement in the peak vertical force, so that's how much body weight they're putting through, and vertical impulse is just another measurement from the force plate. This is the graph, and out here beforehand, so these are the lame legs versus this is control, and over time you can see that they're getting closer together, so there's no difference between the control group versus the lame dogs. That's just what that graph is showing there. So the limitations that we currently have. We have to do anesthesia to collect the fat. That's not free, so we've got to charge for the anesthesia. The processing of the stem cells are, it's 20, I don't know, you can fill us in on the cost of it later, but it's not irrelevant in terms of the cost of processing them. Older and sick animals, their stem cells, first of all, they may have less stem cells, and their stem cells just may not be as robust as those that come from a younger dog, and there may be even some breed variation. You do get that heterogeneous mixture of cells, so it's not just a pure stem cell, it's that's the stromal vascular fracture, which may be good. Maybe we want pure stem cells. We don't know the optimal cells, we don't know the breast treatment frequency, we don't know the effect of concurrent neoplasia, so you have to sign off and say, to my knowledge, this dog does not have cancer, or if it does, I'm okay, that I don't know what's going to happen if I give stem cells and this dog has cancer. So we definitely need additional clinical studies, but they're coming and they're definitely working on it, and I'm not going to steal the thunder. We'll hear from VetStem of what's going on. There are some really cool studies going on, but we're in the early days of understanding the best way to use these. Any questions on stem cell therapy? Yes.
Have you ever had issues in really fit dogs if you can't get enough fat from the falciform ligament?
So the question, have I ever had issues where I can't get enough fat from the falciform ligament? Yes. Yes, because sometimes there are dogs where you are doing all of your other multimodal approaches to OA first, right, which is weight loss, number 1, or they're already skinny. You can take it from the omentum. So the omentum is also another source. So I've done that.
Is it a certain weight?
Certain weight of dogs? Or,
No.
20 grams in a tube. And ideally try and submit 2 tubes. If you don't get enough, I think they can culture. So you submit as much as you can. Or you could try multiple spots, but more recently I've gone to taking momentum if I can't get enough falciform. All right, we're going to briefly touch on platelets. So platelet-rich plasma, autologous conditioned plasma, another form of regenerative medicine. This time we're using platelets. And if you think about platelets' role as a blood cell, when we have a laceration, platelets are the first cells there, right? Because they form our clot. What happens when they form the clot is they release all these growth factors that stimulate healing. So they have all of these alpha granules inside the platelets. Again, when they're stimulated to release, those are full of the magic kind of soup of growth factors. So we use these, or we use PRP sometimes in chronic conditions where we want to kickstart or restart the healing process. So chronic tendinopathy, ligament tendon injury, non-healing bone. Most of them are released within the first 10 minutes. The different commercially available systems have different additives that may or may not change when those growth factors are released. But the bottom line is you give the platelets so that you're giving all of this goodness of growth factors here. And so there are a lot of different commercially available kits now, right? And some of them you use a centrifuge. It's usually a commercially available centrifuge. It's not usually your one that you already have. And it separates out, or there's a filtration mechanism, and it separates out the platelet component. And it may or may not also have white blood cells in it, and it may or may not have a little bit of red blood cells in it. And what we're finding is that there's a wide variation across all of the different systems out there in terms of how much concentration of platelets are they getting. Is it just getting rid of the red and white blood cells and giving you back the platelets in the plasma? Or are they concentrating so it's 5 times the platelets, and maybe a little bit of white blood cells, and maybe a little red blood cells? So there was a study that was published not too long ago, this is out of the University of Georgia, where they just drew blood from dogs and looked at 5 commercially available systems. And actually, well, first we'll look down here is how much blood they needed to get your end result of PRP. And it varied from 9 mils, 55 mils, 29 mils, 44 mils, so a pretty big variation in how much blood you actually needed to take from the patient. And then you process it by the recommended processing, and you get down to, this one was actually, didn't even concentrate the platelets, there was 0.85, so it was actually a less concentration of platelets, versus some who were more concentrated. The bottom line from this study is that there's a big variety in the processing out there. We don't know what is best. That's the frustrating thing. Like, we want to bring PRP into the hospital. Which system should we buy? We don't know that yet. So what I would say is, again, we're going to hear some exciting news in a second, that there are some studies coming out. What you want is a system that has research to support it, that shows we've used our system, and with this system, these are the results that we're getting. And so indications for PRP are going to be quite similar to stem cells. PRP really started taking off with, put these 3 guys together as your example of PRP poster children. Probably not what the PRP world wanted, but they really did make a name for PRP, right? In terms of getting into the media. OA, tendons and ligaments, bone healing, and wounds. You can actually, if you let the PRP sit long enough, you can get a gel form and can use that topically for wounds. So the logistics of it, this is the system that I've used most. It's called Protect. I don't know if it's better or not. It's easy enough to use. It does require sedation to do the injection. I mean, it's a little bit uncomfortable to stick a needle into a tendon or into a joint and inject. So I do sedate them. It must be done with sterile technique. Must. Anytime you're injecting anything anywhere, right? There may be a possible flare, and this is going to be probably more likely to be seen if you're injecting leukocyte, a white blood cell component, or maybe a higher concentration of platelets, so you might see a bigger flare or inflammatory reaction. There's a big debate on whether or not you give nonsteroidals in addition to PRP. And so there's a pretty good argument, and some of the studies have looked at not giving nonsteroidals for 2 weeks leading up to PRP collection, because the mechanism of action of nonsteroidals is that they'll inhibit platelets. So we don't want that on board. I've never taken dogs off nonsteroidals beforehand, but maybe I should be, I don't know. And then afterwards, do we not give nonsteroidals because we're trying to kickstart the inflammation and healing process? again, I don't know, I have taken some dogs off of non-steroidals if I'm really trying to encourage healing for a week, and used other methods of pain management there. So just a couple quick examples. This is Pickles. She first presented to me when she was about 11 months of age, and she was intact at the time. And she had SAP, so this is her elbow arthroscopy. She also had a OCD of her tarsus, which I did treat with stem cells. So she had shifting lameness. She improved with Adequan and NSAIDs, but her job is to be a crisis response dog. That was, kind of what she was born to do. So we collected the stem cells at the time. So I spayed her, did arthroscopy on her elbows, did the CT, and then 2 days later injected her stem cells. This was maybe 4 years ago, and we've had to retreat her maybe once a year. And so preoperatively, this is not an objective outcome measure. It's just a couple pictures I had. But dogs with elbow, OA medial compartment disease often will stand with their toes pointing out, and they're offloading that medial compartment. And so this is how she presented. She was really not wanting to bear weight, shifting off of it, and then that leg was externally rotated. And then this is just a picture. She's been involved in just about every major disaster crisis response that we've had. She was up in Marysville for that school shooting. She was in Oso. She's spent a lot of time out in Oso. And so she's been a very, very active dog, and has been doing really, quite well with being managed with this. This was Kitty. She was a cattle dog, 9-year-old female spayed cattle dog, bilateral elbow OA. She had also previously had hemilaminectomy. So this is arthroscopy showing removal of a fragment. So again, this has kind of been my traditional approach for bad elbows. This was the owner's quote. I feel like I have my dog back. I don't know what you do. You say, that's great, awesome. That's exactly the response you want from your clients when you're treating them. It's not objective at all, but it really did seem to make a difference in this dog. This was one of my very, very, very first ones. This was Taffy. She presented because mom was going to euthanize her because her OA was so bad. And I mean, those are awful, awful elbows. The video's probably not going to play, but she was incredibly lame. And everything had been tried, and mom was going to euthanize her. And so this may be my first or second case ever, and we tried stem cell therapy. And we got 6 months, and mom felt like her quality of life had significantly improved. She was doing things that she hadn't done in years, and she got extra time with her dog that was quality time in her life. These elbows were so bad, I was using fluoroscopy to get into those joints. I haven't needed to do that in any other case, I would say. Oh, no, we do have a video. This is pretty off. I wish I had a video post. It wasn't that much more dramatic. She was just doing things at home, so her activities were different. So my take on stem cells and elbows is elbows suck. We don't have a lot of awesome things to do for them. First is a hip. We can do a hip replacement. We can do an FHO, and we're going to have pretty reliable results with either one of those. Elbows, at this point, we just don't have great surgical techniques. So I do like to combine stem cells, or I have that conversation with most owners if we're going to be switching them, or with young dogs. It's part of a whole multimodal plan. I'm a huge proponent of Adequan. I use a lot of JD, it's weight loss, green lip muscle supplement, so everything that we can pack in there, and the stem cells are just part of that. And it is for me, and the owners do understand that all of our multimodal approach is trying to minimize the amount of non-steroidals usually that we're giving over that dog's lifetime, and that's one of the goals for trying to do stem cells. And then this is just a PRP case. This is Nitro. He, initial presentation, 4-year-old male neutered pointer, high-level hunting dog. He had bilateral shifting leg lameness. It was suspected to be a cruciate, partial cruciate rupture. Turned out he had thickening of both of his Achilles right at the insertion. Now, it wasn't a complete plantigrade stance at all. He didn't even have the claw stance, but he did have thickening of both of his Achilles tendons. And we ultrasounded. I've gotten to work with a really good ultrasonographer who's great at musculoskeletal ultrasound, and we found this core lesion. So anybody who does equine ultrasound is going to look similar to a core lesion. Equine vets have been doing this forever. They inject stuff into the core lesion to get it to heal. So that's what we did. We injected PRP. In addition to shockwave therapy, so it was ultrasound guided. Put him in a custom orthotic that was dynamized or kind of progressed over time to allow more range of motion in that Achilles, along with a home exercise plan. And a year later, he went back to hunting. He was wearing his braces there. I don't have the ultrasound, but it looked like there was good progression of healing. Now the sad part of the story is 4 years later, he's re-ruptured his tendon. So I'm so devastated because I thought we'd gotten this one. So we're repeating the process now. He's had his first treatment of PRP. He's back in his orthotic. But that's basically how I use the PRP and stem cells. So any questions? All right. Well, I'm done. I'm going to turn it over to our sponsors. Get to stand up and give a little what's new. Okay. All right. So Dr. Schaefer from VetStem. So it's a perfect segue. VetStem has some cool things coming out. Dr. Schaefer is a veterinarian who just moved from New York to Southern California yesterday.
Yesterday, as you can tell, I fell asleep in the sun.
All right, I'll turn it over to you. Thank you.
Thank you very much. I'm Dr. Jeff Schaefer. I work with VetStem, and I think it was presented quite well on the capabilities and what's going on with stem cells. VetStem, just to give you a little history, it's done over 10,000 animals. They are in Southern California. And what's interesting also is just their unique process and their quality of the system that they do. Also important to know of the results not only of OA, but the possible clinical development techniques. So being veterinarians, you have an idea, maybe let's try stem cells. You could always call me and give me an idea that you would like to try that. So for example, anyone who has cats with renal insufficiency, and there's not much to do. We have done a history of like 80, 90 cats now, and we're going further with processes of stem cells to help these cats. So if you have any ideas, we have for dry eye, anything, just call me. They put baby in the corner. I'm sitting over there in the corner. You could come and I'll give you my card, or you can tell me any ideas, and we can talk about it. The other thing that's very exciting, besides the stem cell therapy, which is costly, is that we are now coming out with a brand new product, and we're launching it at the ACBS in Nashville in a week and a half, and it is a platelet therapy product, which is, you don't have to buy any capital equipment, there's no centrifugation, and it depicts using I'm from New York, so I say filter. So it's a filter, and using filtration, but I say filter. And it's quite nice in that it has everything in it as you need, everything but the gauge syringe. So all you do is you take the blood, and you can use it from any size animal, from a Chihuahua to a Newfoundland, and you get the amount needed to give the injection to the dog IA. So you just take the blood, you run it through this filter system by gravity. All you need is a hook. You don't need anything else. It takes, when you go through it fast enough, you can do the whole procedure from taking the blood to administering it in 30 minutes. So it's quick, easy, and clinically, it has been written up in JAVMA to show a double-blinded, multicentric study with using both objective and subjective measurements. So they use the Hudson Visual Analog Score from the vet and the owner, where they do an analysis of the dog, but they also use force plate, which is the gold standard presently to do those measurements. And they found a clinical significant difference in treating OA in cases of that with the filtration system. So come and see me, talk to me. I'm lonely in the corner, and